Hello, everyone. Welcome to our mental health session Monday. Our topic today is Black women and infertility. My name is Dr. Nadia Barnett. I am the subcommittee lead for these webinar series, or this webinar series for the Atlanta Suburban Alumni Chapter, representing the Physical and Mental Health Committee. I'm so glad that you all are here today, and I want and hope that you all learned something from this session and continue to follow us on social media. I'm going to turn it over now to our moderator for this evening, Dr. Cherie Hill.
Hi, good evening. Thank you so much for joining us for our final webinar of the year. My name is Dr. Cherie Hill, and I am a board-certified OBGYN and also the co-chair of the Physical and Mental Health Committee. So I'm really excited to join you this evening as moderator, and wanted to first just tell you a little bit about why we're here. So according to the World Health Organization, infertility is a disease of the male or female reproductive tract. And really, we define it as no pregnancy after 12 months of unprotected regular intercourse. It affects many people of reproductive age worldwide, and obviously has a huge impact on our community. Several of you may have seen a special on TV that was talking about the impact of fertility, specifically on the African American community, where sometimes we do not often talk about this topic because maybe it's considered taboo. And so we wanted to really spend tonight honing in on the impact of infertility as a diagnosis, but then also the intersection with mental health and how the stress of infertility can affect the couple and our families. So we have a distinguished panel tonight. I'll first introduce Dr. Sherry Simpson Broadwater. She is the co-founder of her organization Healing for All with her husband, Robert Lee Broadwater Jr., and a pediatric and coaching wellness center here in Atlanta, Georgia. She provides psychiatric care, family coaching to high-performing families caught in the cycle of problematic communication, frustration, and maladaptive functioning. She is also the chair of the Women's Health section for the National Medical Association. Mother-daughter emotional wellness is also a passion for her, and she hosts mother, young adult, daughter wellness events. Most recently, she provided psychiatric care to undergraduate and graduate students at Georgia State University. She's worked as a locums tenens psychiatrist in Georgia and Texas since 2007, primarily in high acuity inpatient and outpatient settings. She has also served as a medical director for Clayton County's Community Service Board. She serves as an adjunct faculty for Morehouse School of Medicine, Department of Child Psychiatry, and was previously on faculty at University of Texas Health Science Center as an attending physician at Baylor College of Medicine in Houston, Texas. She will be recertifying her board certification in adult, child, and adolescent psychiatry this spring. And she completed her internship, residency, and fellowship at Baylor College of Medicine in Houston. She is a graduate of Meharry Medical and Howard University, HBCU Pride, and Dr. Broadwater has presented nationally and locally on women's emotional health, family crisis, racial dilemmas, psychotherapy, physical, racial, and sexual trauma. Her civic roles include volunteering with the Ivy Communication and Alpha Kappa Alpha Sorority Incorporated. So we are glad to have our sister Greek here on this panel today. Next, I am going to introduce Rashaan Monique Mitchell Jefferson, who is our Physical and Mental Health Chair. She was born in Detroit, Michigan, and moved to Atlanta, Georgia for college, where she attended Clark University. She received a Bachelor of Science in Biology Pre-Medicine in 2002, and since then, she has worked as a Children's Healthcare of Atlanta pediatric nurse. She has received many accolades and much recognition for her nursing skills and leadership. She has nursing experience in the areas of emergency medicine, urgent care, primary care, weight management, and sleep management. Rashaan completed her Master of Information Technology with a concentration in healthcare informatics at Southern New Hampshire University, and now works at the Children's Healthcare of Atlanta as a clinical informaticist. Over the years, she has had personal experiences with infertility due to endometriosis that led to multiple surgeries and procedures over the years. And this has helped her to gain a wealth of knowledge firsthand about infertility. So she'll be bringing us that joint experience as a healthcare provider who has also experienced infertility. And last but surely not least, my partner at Emory University, Dr. Jade Stafford. She is an assistant professor in the Department of Gynecology and Obstetrics, and she is board certified in gynecology and obstetrics. She was born and raised in Los Angeles, California, and after receiving her undergraduate degree in biological sciences at Stanford, she matriculated at Howard. So we got two Howard grads here, where she graduated with several honors and awards. Following this, she completed her training and residency in the Department of Gynecology and Obstetrics at Emory School of Medicine. And during her time as a resident, she was recognized for her outstanding research in healthcare disparities, outstanding clinician with a passion for patient care, and she is currently dedicated to being the clinical site director and has a fervor for leadership. Outside of her career, Dr. Stafford is a wife, a proud mother of two sons, and enjoys traveling, concerts, and event for food and wine enthusiasts. And don't call her a wine snob. All right. So thank you everybody for listening to our introductions. And I think we're just going to get right into the meat of it. Maybe Dr. Stafford, you can start us off and just talk to us a little about like what is infertility and what are some of the more common causes?
Absolutely. So thank you for that introduction, Dr. Hill. As you mentioned, infertility is for women under the age of 35 when you are not able to get pregnant within 12 months of having unprotected intercourse. If you're over the age of 35, then actually that shortens to 6 months of trying. And so that is the definition of infertility. It affects about 10 to 15% of women. That's the estimate. However, there are some studies that show that it's twice as likely in African-American women. But as you mentioned, there's stigma and late entry to care and different things that will contribute to that number probably being higher. So some of the causes, we think about it like, what are the different reproductive organs in the female? And those organs can all impact fertility. So first, you would say the uterus having fibroids or polyps. We call those structural. Also the ovaries. So if you have ovarian abnormalities, common problems like polycystic ovarian syndrome, that's something that people hear of a lot, PCOS, thyroid disorders, all of those things can contribute to ovulatory dysfunction. Also changes in weight, extremes, either really low weight or obesity can also contribute. And then the tubes, if your tubes are blocked, that will also increase your chance of infertility. So we think about those structural causes as well as the ovulatory dysfunction. There's also male factor. So males contribute to about a third of infertility, and that's going to be contributing from sperm abnormalities, or also metabolic conditions such as diabetes can cause infertility in males. Also, there's unexplained infertility, which affects about 10% of couples, and so that's another reason or cause for infertility.
Well, thank you. Yeah, that's great information because I think sometimes as women, we often feel like we have to shoulder that burden of the diagnosis of infertility. And so knowing that it's truly a couple's diagnosis, I think is a really good take-home point from that part. I know we said that it can impact Black women, potentially more. Why do you think that is? Does it have something to do with those increased risks that you already mentioned?
I do. I think it has to do with that. I think there's also obviously structural racism. That's something that affects us in every way, especially in healthcare. I think that if you have a physician who, as we know, patients who see doctors that look like them get better care. So having that conversation with your doctor, especially at an early age, and being advised of your risk, and being advised of the likelihood of you being able to get pregnant, what your options, resources are, that also impacts your opportunity. So I think, having it be late, like you're 39 or 40 years old, you've never had this discussion with the doctor. And so now you're entering into desiring fertility care and your options are less because the greatest risk is age.
Yeah, that definitely makes sense. Maybe I'll bounce things over to you for a second, Rashaan. Maybe do you mind telling us a little bit about your first interface with your physician as a Black woman? Was it something that they mentioned to you, or did you have to seek that out? And do you think that your role of being a nurse helped you navigate that journey?
So it actually was never really presented to me as being like an infertility diagnosis. I think I got the diagnosis of endometriosis maybe in my mid-20s. And I had a couple surgeries, leading up to that, from scar tissue, a lot of polyps, had an ovarian torsion. And I was getting surgery almost every 3 months. And then one day when I went to go to the doctor for a follow-up, and they said, well, you have more cysts, and we can't keep doing surgeries. It's going to lead up to this scar tissue. So you have two choices. Either what can help this is for you to have a baby, mid-20s now, right? Just graduated from, undergrad like 2 years ago, not established yet. Or that we can do a partial hysterectomy. I mean, it kind of like puts your back against the wall, because you're just like, what do I do? I think that was after surgery number 4, and I was like, I can't keep doing this. So after some discussion, that the choice was made to have a partial hysterectomy. And then it was so much scar tissue in there that I don't know. I figured that my infertility was due to the hysterectomy, which it was probably before that, with all the surgeries and scar tissue. One thing I will say is that nobody ever, I think now, going through fertility treatment and everything, which we'll probably talk about later, after the surgery, I wish that I had been given some more knowledge. I wish there were some more tests when, you would go for your annual pap smears, to do those AMH levels and all those things that just tell you your picture of fertility. I don't think I was given the full picture to make a very educated decision at that young of an age. I think it's something that should be done, at your annual pap smears and everything. I just think it's a huge lack of resources out there, which is why, especially with Black women, why it's affecting us so bad.
Well, thank you. I mean, having been on like the doctor side and knowing what it takes just to have one surgery, and hear that you've gone through 4 surgeries and so much. Just thank you for being so open and sharing your story with us today. And I know we're going to continue to hear more of it as we go on. Things I heard is that it wasn't brought up to you. And somebody asked in the chat, how do we bring it up to our doctor? And so I think, Dr. Sherry, this might be a good question for you. Speaking about good communication, what's a way that maybe a patient can help advocate for themselves to start having this conversation? And then if anybody else wants to pipe in about the timing of that conversation, that would be great.
Yeah. Well, one thing, I'm going to step back just a bit. I think one thing that happens as for busy professional women, many of us are moving around from place to place. I mean, I know as physicians, we have medical school, and then we go into residency. And so we may have moved several places, and intimacy and closeness is needed. So we want to be able to connect with our physicians, know our physicians, and they really to know us, as well as there be some longevity, and that helps to bring us together. So one thing is, it's important to have a treatment team, and these are the people that you are committing to share and partner with you. And then also making sure that you are well, this is how I think about it. I'm partnering with you. So when patients come to me, I'm just helping my patients be the best them. So it is expected that you bring information to me so we can discuss it, because if not, then, and I do have some patients who want me to sort of control the narrative, control the conversation, but I do ask and encourage patients to bring what you're reading, bring your notebooks, bring your family, bring the questions. And I think as Black women, we've got to also be having these conversations with our friends. Are you talking to your doctor about XYZ? Are you saying what you should say, could say? What are your personal goals? Because so many of us also don't have those honest and authentic and upfront conversations with our sisters. And then that becomes a barrier to us talking to other people about, or advocating for ourselves. So it's multi-level of things that we need to do. We can do better.
I absolutely agree with that. I think from my perspective as a physician, when I'm taking care of patients and seeing them and establishing that relationship, I actually start this conversation with them in their 20s in order to discuss, what are your plans at this time? Of course, those can change, but what are you thinking? Do you think you want to have children in the future? Is that something you're interested in? If it is, let's talk about it. What's your timeline? How many children do you want? Just to get the conversation started and kind of demystify it a little bit and bring down their guard about that conversation, because it can be a little bit, unsettling for some people, or, they have trepidation about bringing it up. So for me as a physician, I take the responsibility on myself to discuss that with my patients.
And I will say, one thing I did not mention, and I don't know if this is a factor, but I think it probably plays a part, is that at the time, historically, I had male physicians and specialists. So I didn't have, a female GYN, and, I was young. I did, they had been my doctors for years and they were great, but I don't know if it played a factor, but I would just encourage people to get a female GYN.
Yeah, I'm not going to argue with you on that one. I think that that's great advice. So yeah, this is great conversation so far. I know you mentioned, Dr. Stafford, that you bring this up to your patients and sometimes start the conversation in their 20s. Are there certain times that, like at an annual, that the patient should ask for fertility testing? I heard you, Rashaan, mention the AMH. So maybe Dr. Stafford, you can tell us, like, what is the AMH, and is that something that a patient should come in the door asking for?
Absolutely. So AMH stands for anti-Mullerian hormone. It is a hormone that we test for that gives us an idea about ovarian reserve. However, its utility really is for how well you'll do with treatment, assisted reproductive technology, and it's not really the best gauge of exactly how well you'll be able to get pregnant on your own. So it is useful, but the American Academy of Reproductive Medicine actually recommends not getting that test until you're 35 years old. So it's not recommended in our literature until 35, which is why a lot of doctors aren't offering it. If you request it from me, I will order it for you, but I just want you to know that that's not our standard of care. And so that may be a reason why it's not being ordered or offered. There are other tests that we can offer and order, and it also depends on a lot of other things that are going on, your menstrual cycles, your history, like all of that needs to be taken into account to decide what do you actually need. And that's why having that intimate relationship with your doctor is important.
Excellent. Yeah, I think that is obviously very evidence-based. So thank you for clarifying, like, what you do versus what the books say. So that's good to know. And I'm starting to see the questions into the chat and from Facebook. So thank you for asking those questions. I'm going to get to some of those now. We're going to continue first, just like on this notion of kind of diagnosing infertility. And I see two questions related to a condition called PCOS, or polycystic ovarian syndrome. And we don't have to spend too much time talking about what it is, but maybe like a brief discussion of, like, what is PCOS? And then I think pertinent to today's conversation is, if you are told you have PCOS, does that necessarily lead to infertility? And I know for some women, when they're diagnosed with PCOS, we often put them on oral contraceptives to regulate their period. Does that then impact fertility later on? Dr. Stafford.
Yes. So PCOS is a condition by where patients are not ovulating regularly. So typically they'll only have, 3 or 4 periods out of the year instead of having monthly periods. And so because of that ovulatory dysfunction, they basically have difficulty getting pregnant because you need the menstrual cycle to continue normally for you to get pregnant. So I would say that it's not something where you're guaranteed to have infertility, but it can make it more challenging, and you may need assistance to increase your opportunity for ovulation so that you can get pregnant. If someone tells you you have PCOS, the recommendation, particularly if you have or struggling with obesity, is to try to lose weight with diet and exercise. Sometimes that alone can help regulate the cycles. You are right, we do put patients on oral contraceptive pills in order to help regulate the cycles and to decrease symptoms and side effects. That does not impact your future fertility. Once you stop the pills, your fertility is what it is at that age.
Excellent, thank you. So I hope for those of you asking about PCOS, that makes sense. I think it's something that we definitely, consider when we're thinking in the future about infertility, but it's not like you all of a sudden get like an extra seal that says you're going to have infertility just because of it. And don't be shy about taking those birth control pills because it's not going to make you infertile. Maybe we can segue a little bit into, and maybe this can be a question for Dr. Sherry, about kind of coping with managing some of these diseases or diagnoses that a patient may have when they come into the office. So for example, they are told they have PCOS, or maybe they are told that they can't get pregnant. What are some ways that they may then interface with a psychiatrist? How do you tend to overlap with this process?
And I was thinking about a similar question earlier. And I didn't come up with a good answer. So I'm just going to try to pull my thoughts together around it. That I think that infertility and what it means and the reasons why, I think is one of the most life-altering experiences that women have, just like potentially death and divorce, because it hits us at our core of who we are, just like changes in relationships and changes in the life people living or not living. That at our core we are givers, caretakers. It is a normal, natural desire to give, and then when infertility hits us, here we experience it, then we have to do lots of reconciliation about who we are and what we want. And because of that, it requires on our journey the reproductive commitment, but it also requires an emotional and psychological commitment. And as Black women, so many of us are so busy working and achieving, and we have families, that even before the diagnosis, we haven't spent so much time carving out what is mental health for us. And then the diagnosis comes, and then many times there's not even any room for us to figure out what that looks like. So I think the more we can recognize that, yes, this reproductive part is going to take my time and effort and resources, but for me to create and maintain emotional wellness, that's going to take more time as well. And so one of the things that I encourage most of my Black women to do is to look at where their time is being spent. And that if we're working 40 hours, we're getting paid for 40 hours. We're not working 48. We're not working 53 or 42. We're working 40 hours. So we're really learning how to set boundaries. And so we're transitioning out of work appropriately. That means that we have time to be healthy. We have time for healing. That means we are creating the foundation of healing, which is the bread and butter. Are you eating 3 meals a day? Are you having healthy snacks? Are you hydrating? Are you sleeping 8 hours a day? Are you exercising? And these are the fundamentals, because we know that to be healthy, mentally healthy, we need serotonin. You get serotonin from what you eat, healthy eating, and from exercise. Many of us are not consistently eating well and consistently not sleeping and exercising. So that's the fundamental. The second part is really focusing on what it means to be mentally healthy. That means that we have a life purpose. That means that we have a variety of friendships and connections that feel good and that nurture us. We have a variety of activities that nurture us and make us feel good. Most of us, and this goes across demographics, have like 2 or 3 things. So we have to spend time creating wellness. Is also being flexible, being realistic, being able to learn, being able to manage our feelings. And again, all of this takes time, and all of this often is not time we have dedicated to doing. So that is where I start. And then, of course, the assessment about how are people really doing? Because if we got to a point where irritability, jealousy, grief, depression, isolation are the main feelings and emotions that we have, and we cannot shift out of them, then that definitely is an indication that formal interventions with a counselor, therapist, psychiatrist, even primary care doctor really needs to be considered. And that goes for our mates too, because our mates can be are often suffering the same or experiencing the same feelings that we're having. And so we got to have enough room to recognize it for ourselves and also help our partners recognize it within themselves.
Excellent. Yeah, I love like you go into the fundamentals, even if you're not going through infertility. I think that's great for overall wellness, and it's something that I at least endeavor to achieve on a weekly basis. Rashaan, tell me a little bit about your experience when you were kind of discovering about this diagnosis of infertility. Did they recommend that you also see a psychiatrist? Did you go to your primary care? Did you rely on family? What type of support did you do or have?
At the time, those wonderful men did not recommend that I go to any kind of counseling. I did not start until I switched to a female physician. That even going through my fertility later, after my partial hysterectomy, I knew that from that on in my mind, I was like, okay, I'm going to have to get a surrogate or adopt to have a baby, right? So it was, and it was a partial hysterectomy. I still had my ovaries, I still had my things that work. I just couldn't, carry a baby. So I was just like, okay, this just might be a little bit different. So in my mind, it wasn't like the say all do all. It was just like, okay, I'm just gonna have to take another route. I mean, it was part of me that kind of, pregnancy kind of freaked me out anyway. So, but to each his own. So when I started on after I got married and we started going to fertility doctors to explore surrogacy, they were just like, okay, well, you need to do some counseling. And I'm just like, wow, no, this is what I want to do, right? So I get it. I definitely get it because, everybody goes through this different mental process, just like Dr. Sherry said, you go through all the emotions. I have some other medical diagnoses and hearing those, I give myself like 3 days to just feel all the feelings, hurt, anger, resentment, give myself 3 days and then you just figure out what you want to do. Right. So I think, it is important to go through that process, talk about how it's going to make you feel, because I think it is necessary. You can ask all the questions, you could talk about your feelings if it makes you mad, if it hurts you, if you don't think you'll be able to accept this baby as your own, I think it's important to talk about that. And I'm glad that I had good physicians that recommend that, and they recommend it as part of the process. like you have to do this, because we need to make sure that, you know, you are 100% on board with it. And your mental state is just like, okay, I'm going to care for this child. I'm going to love this child, you know, regardless. So I appreciate it, you know, that it's part of the process. So, yeah.
Yeah. And I like, to your point, if it's part of the standard of care, then it makes it so that hopefully nobody slips through the cracks, right? I mean,
Right.
I think when it becomes the physician is the gatekeeper for access, that's where Black women end up getting the short end of the stick.
Mhm.
Because people will think, oh, they're a strong Black woman, you know, they don't need counseling, they don't need to talk about this. And so when it becomes part of like, this is the process, then all of us can benefit from that process being set in place and having that access available. I see Dr. Sherry wanted to piggyback on that.
Yes, I wanted to make sure I add this. Thank you, Rashaan, which reminded me of this, that many of us underestimate the impact of untreated depression and anxiety on our bodies. The clinical depression and clinical anxiety disorders are physiological stressors on the brain and body. And they drive inflammation. And we know inflammation is a big part of, it disrupts everything, including cardiovascular disease, kidney disease, fertility. And that is another reason why when the physician suggests counseling, it is to help us be well, to manage our stress, and to decrease the depression and anxiety, or even just it doesn't even have to be that, but just stress, because African-American women experience adverse negative events more than almost any other group, and that includes adult Black women. And all of that stress that we're likely not managing, but so well, is highly contributing to inflammation. So when the doctor suggests that, that is the main reason we're trying to reduce the stress, reduce the inflammation, which is going to allow the body to do what it wants to do, which is give you a baby. Okay. It took me about 2 years, and I went to therapy. This is my disclosure, because some of us go to therapy, some of us don't go to therapy, but I ended up going to therapy for 2 years. And it was one of the best decisions of my life, because I was caught into this cycle of thinking and I just could not break it. And what I told myself was, because it was a breakup and my husband just came down. Okay. I think he knows this. Sherry, if you think this thought one more time, it's you. I was about 37. And then what happened? Of course, I thought the thought again. And so I forced myself to go to therapy. I'm telling it changed my life, because it helped me to break the cycle of a thinking patterns that I could not break by myself.
I actually think it shouldn't just be for infertility. It should be part of the process for infertility. It just needs to be part of the fertility process. Like if you're you know, because everybody is not ready to be a parent, and people don't know that they're not ready to be a parent. And some people are just not, you know, physically, like you said, they're not capable of separating themselves from work, and they don't have a good work-life balance. So having a baby is probably, you know, they need to talk through that process. So I think it just needs to be part of the process, period.
Yeah, I agree. And Dr. Sherry, thank you for sharing your own experience. You know, I think sometimes we often think that, you know, psychiatrists or physicians, that we don't go through life experience as well. And it's really nice for patients or potential patients who may be on the phone to know that we're all living this human experience and can benefit from these things too. So thank you for sharing. We've got a couple more questions on the diagnosis piece that I'd really like to get into. And then soon we will talk a little bit more about the treatment part, and then kind of the mental health impact about going through treatment. So somebody specifically, and I guess let me take a step back and say, you know, even though we are physicians on this call, we are not your physicians. So if you have specific questions about you and your own diagnosis, please make an appointment with your own physician. we're talking about big picture concepts and not necessarily your specific diagnosis or treatment plans. I just want to be clear about that. But in general, Dr. Stafford, I'm going to turn it back over to you. How does hypothyroidism play a role in fertility?
So thyroid dysfunction and any hormone dysfunction really has an impact on your fertility because all of the hormones intersect. They all interact with one another and impact one another. And so having super high levels or very low levels will impact what your ovarian hormone levels are, the hormone levels in your brain. So all of those work together. And so that in general can impact, without getting into specifics, your fertility.
Yes, and so kind of continuing on this hormone path, somebody asked, well, maybe I'll make this a two-part question. What are your thoughts on checking hormones and like, what does that mean? And then are there certain supplements that you think somebody needs to be taking to help with hormone levels?
That's great. So the first part, I'll say, wait, what was the first part?
Do we need to be checking hormones?
Thank you. Okay. So in terms of checking hormones, what you need to understand about checking hormones is that it's literally a snapshot in time. So checking your hormones now is not going to necessarily determine what is happening for your future. And so it can sometimes give you a false sense of security if everything looks great, but then later on it's different because you've aged. So it is something that can give you a little bit of information, but it's not something I routinely do because I don't think it's going to really help give you what you're looking for, which is reassurance. And then the second question was,
are there supplements that are like helpful for hormone levels?
Yeah. I do not know of any specific supplements that will help with hormone levels. Dr. Hill is also an OBGYN, so she can answer if she knows of some. But I would recommend, just like Dr. Sherry said, to really think about this from a holistic approach, thinking about taking care of yourself, exercise, diet, eating well, taking vitamins, all of those things, taking care of your mental well-being are going to help steer you in the proper direction toward achieving your best fertility at that age. And so that's probably what I would recommend over specific supplements.
Yeah, I wholeheartedly agree with you on that. I think that I often have conversations with patients in my office about we don't always know the impact of stress on the process of trying to conceive, but we know it's probably not a good thing. And so all the things that you can do to get your life in order, to get your routines in order, to take care of yourself the best that you can take care of yourself are only going to help you if when you get pregnant. They're only going to help you if when you have a child, whether it is through your own natural conception or when you adopt or whatnot. All of these things are huge life changes. And so you want to have all of those kind of processes already in order. So I think that's wonderful advice. And for my wellness ambassador hat, definitely agree with that. So along the lines of kind of thinking about some of the diagnosis of infertility, tell me what secondary infertility is. There's somebody in the chat who made a comment that said they're amongst a group of women where they were only able to give birth to one child and that this is more common than they realize. So what do you think the cause or what might be going on there?
Yeah, so secondary infertility is defined as infertility that occurs after you've already been able to successfully have a child. And there are a number of causes. As I've stated before, age is really the greatest factor. And so as you age, the chance of infertility increases. And so that's one of the main contributing factors. But there can be other things. You've lived life, and so maybe you've had some impact from the tubal factor. Maybe you've had an infection, maybe you've had surgery, maybe you had a C-section, maybe you had, there are a lot of things that can impact what's happening going forward, in addition to hormone changes that happen with age. And that a lot of that happens, from your genes, what happened with your mom and your sister and all of that. So those are things that can impact and cause secondary infertility.
Yeah, I think that's great information because sometimes you figure, okay, I had my one, so I'm good. That infertility, that's not my problem, and then it sometimes catches people off guard when they struggle to have that second baby. So a couple of more questions about PCOS. So we already talked about PCOS being this condition where you don't ovulate frequently and therefore you have less chances, so to speak, in a given year to potentially become pregnant. So somebody was asking if you could explain the difference between like PCOS and premature ovarian failure. And then is that something that then means, I'm not going to be able to have a baby?
Sure. So PCOS is a different type of ovulatory dysfunction because it is something that generally starts in your teens and 20s and is ongoing for years. And it has a lot to do with you not ovulating regularly, as I stated before. Whereas premature ovarian failure, it's really the ovaries are kind of shutting down prematurely. That's the best way to describe it. Where, the average age of menopause in the United States is 51, but for somebody with premature ovarian failure, the idea is this menopause and perimenopause is starting earlier for you. So that's someone who you want to seek fertility treatment sooner so that you have, a narrower window to act. And so you basically want to seek that treatment out sooner. I wouldn't say it's something where it's like inevitable that you'll never be able to have a child. I'm not really the type of doctor who gives that kind of advice. I don't tell patients, oh, you'll never have a baby, or like, that's not my zhuzh. So I feel like, everything has an opportunity and we can work together to meet your goals, and let's do that. And so I think that with, getting in to see a fertility specialist, as I stated, I'm a generalist. So I usually am like the first stop or the front door entryway into a referral to a fertility specialist. And so if we notice that's something that's going on based on what's happening with your periods, you're not having them, you're having other symptoms like hot flashes, night sweats, things that symbol menopause. Most people with PCOS don't have those. Then I would say, that's something that we would discuss you going to see a fertility specialist. Hopefully that helped answer that question.
Yeah, no, I think that definitely clarified the two, because they're definitely different, even though they seem like they may kind of intersect at a similar endpoint. And I'm going to kind of bounce things over to, I think, Rashaan again, about your journey to seeing the fertility specialist. We're going to start getting into treatment, and I was hoping that you could tell us a little bit about maybe that first discussion that you had with your provider about treatment and kind of how that impacted you, and then we'll move a little bit more into that part.
Sure. So, well, my husband and I, we knew that we wanted to still, have a family. So we first went to, I think it's AMIX, Atlanta Medical, Atlanta something, fertility and reproductive specialists, like that. And I did, you have to me, like, I have to be very comfortable, because the process of fertility, they really dig into your personal details, your sex life. They want to know all the things. And I didn't feel like the warm and fuzzies there. But I do have like a thyroid cancer diagnosis. So we started there. I had to have another surgery, so we had to stop. I had to have another radiation. So 9 months after that, we went to Shady Grove. I heard a lot of things about Dr. Monica Best. I love her. She is absolutely amazing. And we had a very in-depth conversation. She was just like, I think once she asked occupation, she knew I was a nurse, but I was like, don't talk to me like I'm a nurse though. Just talk to me like, I'm a patient and I know nothing about this. Because I think sometimes when they learn that you're in the medical field, they start throwing all this medical jargon at you and you're like, I don't even know what you're talking about. So it's that I'm a pediatric nurse. We don't talk about, GYN stuff that much. But the first conversation was like, okay, tell me your thoughts. Tell me what you want to do. Like she listened. We had a dialogue about surrogacy, the different options available for surrogacy, like gestational, if it was going to be somebody I knew, the process, the cost. And they do recommend supplements like CoQ10, DHEA, if you're going to go through an egg retrieval. So we talked about, we were in there for about 2 hours, and that was just me and her. So first she meets with the patient. And then it's, she brings my husband in, like, a couple sessions later. They do a number of ultrasounds. Since I had that partial hysterectomy, they could not track my cycles because I don't have them. So I had to go in. I mean, it was a ton of blood work, a ton of ultrasounds, a ton of labs just to try to figure out when I ovulate. And then, all the labs to see what my ovarian reserve was and if it was too high or too low. And based on that, then they would say, okay, we need to do this process called ICSI, which I had no idea what that was, right? So it was just like they give you everything, and it's very overwhelming. It is an overwhelming amount of information. I was just like, oh my God. So, it's just, I would just tell people, be prepared just to stay in there for hours, but be comfortable with the doctor that you chose. Do your research, read those Google reviews, ask your friends, because a lot of people go through fertility and they don't talk about it. So some of your friends have been through fertility. So ask your friends, be very honest. You have to be, I think you have to get to a place of being comfortable with asking the hard questions. I am a data person. I want to know statistics. I want to know numbers. I want to know, give me my percentage. So Dr. Best was very good with just laying it all on the table, but she left the practice. So shortly after that, I had to have another surgery, another radiation, had to wait another 9 months. And that's when I got the message that she left the practice. So now I went to Emory because all my other specialists are at Emory with Dr. Marcity, who I absolutely love. She is an open book. And I feel like we're like friends. We talk like we're friends. And I was just like, okay, give me the whole, don't give me like, I'll do what you want me to do. I said, don't give me that speech. Like, give me the data. Would you do this? Is this even in my best interest to go through surrogacy, everything, because the timeline is massive. The amount of money is massive. And after some very, very, very in-depth conversations with her, we decided on newborn adoption. I know. I feel like I've been like around the world. This is after like going through so many tests and everything. I just was like, give me the statistics with AMH of my numbers, egg reserve, everything. Give me my percentage of, having a child from my eggs. And I was open to using a donor egg. Donor eggs are $10,000 for 6. I don't have $300,000 laying around. Like, it's just, you have to be very realistic with what you want and if you can do it. So it's not enough resources out there for women in general who have infertility issues. It's you have to be one of the Kardashians out here, so for us, it was just what was best for us in our situation. And that's the short and long of it.
Well, thank you for being so vulnerable, like I've said from the start, with your whole story. I know that you have been through so much, and somebody mentioned in the chat that you have a powerful story and that it's very touching and informative. And so just thank you there were so many nuggets in there. I think the first nugget that I'm going to latch on to and kind of punt this to Dr. Sherry is, you mentioned about being overwhelmed, and somebody kind of piggybacked here and said, there isn't always enough information and resources, but then sometimes you go to the doctor and you're flooded with information. Dr. Sherry, how do we help women or patients deal with the overwhelm that can come with this new diagnosis of infertility and the discussion of treatment plans?
Well, I think one thing that we can do is give ourselves grace and compassion, and also probably slow our timelines down, because as professional women, most of us are accustomed to doing things on our own timeline. We can, and we've been affirmed by setting a goal and that goal happening when pretty much when we think it should happen, or there's, it's maybe just a little bit later. But this journey here, you will not be able to control in the ways that you've done in the past. So being able to relinquish control, that's number one. Number two is making sure you're talking to your partner about maybe delineating what his role is, or what her role or is in your role. I'll take this part, you take this part, so that it's not just one person doing it. And if a partner is not willing or does not take on that role, then that's something that really needs to be talked about, because that issue has likely come up before and will likely come up again once baby is here. I think also making sure that we have friends, like Rashaan said, healthy friends, where there is the reciprocity of more intimate conversations, so you're able to talk about some things, and that also may be friends and family members. I underestimated how open my mom would be about where we were on the fertility journey. And I think one day up in my bedroom, I said, what are your thoughts about a donor or something? She was like, okay, when? Tomorrow? And I was like, what? And I just thought that, I don't know what I thought, but I had imagined that there was going to be some friction or some tension, and she would be surprised. And here she was, not saying anything because she doesn't want to make me anxious. And here she is waiting on a grandchild. And I'm like, oh my goodness. So I think talking to parents and friends about hard conversations, and even working on having hard conversations. There's some things that are coming up that I would like us to discuss. There are some things that I haven't really discussed in the past. How can I bring them up? How do we create a emotional safety? Your mom or your parent, your friends might be like, what were you talking about? Let me explain that I can talk and feel and be vulnerable and be heard and be validated and not shut down. So you may have to go through those things with your friends and family, so be able to create that space. And also, there are also Facebook groups and also other types of support groups, but it is essential that we create a village of support around us to get through.
Yeah, I 100% agree with that. It takes a village for so many things that we're navigating as Black women, and particularly this issue. One of the other things that you mentioned, Rashaan, was about donor eggs. So I'm going to give this one back to you, Dr. Stafford. It's related to eggs. That's the segue. It's really first talking about egg freezing, so a little bit of a precursor to this, and then we'll talk a little bit about egg donation. But do you recommend egg freezing for your patients that are at a young age, or maybe they're not partnered? And then, I don't know if you guys remember this, but I know when I was on the college campus, there were always signs about donating my eggs. So if I needed a little cash and decided to do that, does that then prevent you from having kids later in life?
Okay, great. So to answer that second question first, if you decide to donate eggs in your 20s, it does not prevent you from having kids in the future. It doesn't impact your fertility in the future. So if you want to do that for extra cash, you definitely can. And in terms of egg freezing, so my general practice, as I mentioned, is to start, especially if I'm starting to see my patients younger in their 20s, and we're having discussions about their future plans, and they say to me, okay, I want to have a baby in the next, let's say they're 25, and they say, I want to have a baby by 30. Well, I see them every year, and now we're here at 30, and I say, remember, you told me at 25 you wanted to have a baby by 30. Where are we in that process? And then we discuss where they are. Oh, well, I'm not married, and it's really important to me to be married. I haven't found a partner, but having kids is really important. I want 4 kids. If all of these details start to unfold, then I typically do say, well, I think it's worth a consultation to discuss freezing your eggs. Most of the time, people are leery of it because they're afraid of cost, number one, and number two, the process. And so my advice about that is that you generally don't know the cost until you investigate. So what typically happens at most fertility offices is they have a financial counselor available to you who can talk to you at your consultation about what is actually covered by your insurance and what would be out of pocket, so that you can know how far in the ladder you can climb without having out-of-pocket expense. Because sometimes there are things covered like ultrasounds or lab tests that you wouldn't even think, but they add up significantly in the overall cost. So having that discussion and consultation can help to alleviate some fear, can help to really guide your decision in the future, can help you to make an educated choice, as opposed to it seeming like this nebulous thing, like, oh, I don't know about egg freezing, I don't know what to do. Like, let's have that conversation, let's have the meeting, the discussion, and see where we can go from there.
Yeah, I think that's a great approach. I love that. And somebody is asking in the audience where you see patients. So I'll be sure to put the phone number in the chat, but she's at Emory OBGYN. So you could definitely make an appointment with her. So I'd like to also have you kind of continue this conversation. I know Rashaan mentioned some big terms like ICSI and IVF, et cetera. Maybe we can talk like entry-level fertility treatment. Especially, I know we've heard a lot of discussion about PCOS. Maybe, it's one of the more common, obviously, ovulation disorders. So what are we offering for women with PCOS? And then on to kind of the more invasive fertility treatment.
Sure. So I'm going to start by having some transparency. So I myself am a generalist, as we stated before. So that means I'm not a fertility specialist. However, both of my children are IVF. So I have the perspective of being someone who is a physician and OBGYN who has undergone fertility treatment. And so I think I bring that to the table when I'm counseling my patients. So because I have that background, I can give more information about the process. So in general, I would recommend starting with your general OBGYN, having a discussion about what's happening with you, what your concerns are, what your goals are, and then you guys can make a decision together about where to go from there. If you are having PCOS or ovulatory dysfunction, what I would recommend, or at least in my practice, what I do feel comfortable doing, is giving a medication that can help to induce ovulation or help you to ovulate. And so I'm willing to do that, generally speaking, for like 3 months. And then in the interim, I am referring you to a fertility specialist. So in this way, we are doing something together to manage the condition while I'm referring to someone who can do the next level of care. So typically when you get to them, they, as I stated, have a consultation with you, which is generally covered by most insurances, and a financial counseling session. They give you information about what the steps are that need to be done. As we discussed in the beginning, we think about different areas of the female reproductive tract and how that can impact your fertility. So we want to test for those. So that means ultrasound, that means a hysterosalpingogram, which is an X-ray that looks and checks the opening of your fallopian tubes. We check the sperm to make sure that it's normal. We're going to check blood work and labs. And so all of that together, and an antral follicle count, which counts how many follicles are in your ovaries. So those are all initial steps in the process. And then after that, they will counsel you based on your results about what you need. So do you need ovulation induction, which is medication, plus having sex at home? Do you need ovulation induction plus them putting in the sperm inside, which is intrauterine insemination? So you would come into the office and they would actually inject the sperm into your uterus. Or do you need IVF? What IVF is basically taking the eggs from the female, the sperm from the male, and putting them together outside of the body to fertilize, and then seeing if they grow into normal embryos, and then putting those back inside of your uterus to help you to get pregnant. So ICSI is a way to basically put one single sperm into the egg. So that's more specific. So that's a general overview of fertility treatment and what to expect in the different tiers.
And then is there an age limit for this? Is there a certain point where we need to just go right to thinking about adoption or alternative means of becoming a parent versus using donor eggs? How does age impact that?
Oh, that's a great question. So typically I say, a lot of women are afraid, oh my goodness, I'm about to be 35. The shoe's about to drop. I'm not going to be able to have any children. It's going to be so terrible. And that's actually not the case. A lot of women successfully get pregnant and have children after age 35. I am one of them. And so I think, to not feel like it's utter doomsday by having that conversation is really helpful. I would say once you start getting closer to 40, then it's really time to think about your options, freezing eggs if you haven't, seeing, how many can you actually freeze? What's that process like for you? Because then that can give you an idea of, well, will you need donor eggs? Once you're getting into your 40s, particularly by age 43, that would be strongly recommended because the chance of natural conception is just so significantly lower. The chance of them getting normal eggs out is going to be significantly lower. I know we know about Janet Jackson having a baby at 50, right? I suspect that Janet might have frozen her eggs because I think, it's unlikely, but it gives the general public a false sense of hope that, I can have a baby at 50 and it's all good and normal. When in reality, there is a timeline on how the quality of your eggs is going to be as you age.
Yeah, I think that's a really, really important discussion. And I know you mentioned you're a generalist, as am I. And I recently asked our fertility center kind of what their cutoffs were, and they will, quote, allow you to use your own eggs even up to like age 47. At that point, they're going to say, hey, like literally the chance of a natural conception is like less than 1%. So I'm not going to like exploit you and take your money because it's not likely to be successful. And the other thing I want to kind of piggyback on with the egg freezing conversation, I have that conversation quite often with my patients. It's a nice like insurance policy, but even still, it's not a guarantee. And sometimes you can freeze your eggs and then they don't survive the thaw. So, I don't want to put too much hope in the egg freezing discussion either, because sometimes the eggs get frozen, but then we can't fertilize them once they're thawed. So it's just for level setting and just being realistic with expectations about the likelihood of a live birth with egg freezing. It's an option if there aren't other options for conception right now, but it may not always lead to a live birth.
Oh, that's absolutely perfect. I agree with you. I think one thing to keep in mind is that the general statistic is that it takes 6 to 7 eggs to make one embryo that's going to be viable. So keeping that number in mind is really important. And that generally the viability of embryos is better than eggs by themselves. But that means you have selected this particular partner and that is what that is. But those typically thaw better. And so that's generally something they recommend if you are partnered.
And then just continuing this treatment, I know we talked a lot about women, and you and I both take care of women or patients that have uteruses. What about men? I know we mentioned that a third of the time it can be male factor. Is there treatment for men? And then I'm going to segue over to Dr. Sherry. Like, how do we help couples then cope with this diagnosis of infertility and seeking treatment?
Yeah, so depending on the cause for male factor, I would recommend going in different directions. So if it's an issue with like diabetes, hypertension, something like that, then I would recommend starting with a primary care physician. However, if it's a sperm quality issue, then I would recommend seeing a urologist. And typically your infertility office will have a urologist that they recommend to you to help ease that process, to segue you into that avenue if male factor is an issue, so that you can get treatment depending on what the cause is.
Yes, thank you. Yeah, we work really closely with their office as well. So Dr. Sherry, can you talk to us a little bit about, just helping the couple or the individual cope with this diagnosis? I think you're on mute.
Thanks. I'm going to start with the social village and then go inward. I think a couple things that we can do is begin to ask our friends and families, how would you like me to bring up hard topics? How would you like me to bring up topics that are uncomfortable or maybe fragile? So I think just those questions being just a part of what we already are asking are very important, and it's specifically about the issue. So if, let's say you have disclosed that you've been diagnosed with infertility, and even and then on our parts, telling people how you would like to be supported. How many times that you would like to be asked? How frequently would you like to be asked? How would you like the person to express the concern? When I'm fine, it looks like this, but when I'm not fine, these are my indications that I'm not fine. And friend, this is what I need at that time. I need space. I need you to come over and do nothing. That means come ask me to go for a walk to distract myself. So I think that this is a part of being mentally healthy, right? But in this particular issue is what I think brings it to the center that many conversations have not been had. Okay, so that's one thing. Another thing that I think we can do is commit to mindfulness and relaxation. And many of us don't have a set plan for that. Many of us have not done it or don't have in terms of actually being able to focus on the now. I think yoga is excellent. Independent of our religious stances, but just teaching us how to stay in the moment. And then hopefully we can generalize and we can practice that on a regular basis. Another thing that can be helpful, even if it's a short-term psychotherapy, is CBT, and that's cognitive behavioral therapy. And actually, people can pick up cognitive behavioral books. And what it is a retraining of how we come to conclusions. So like one thing that people can do, so there's like 15 or 16 different types of thinking errors that drive depression, anxiety, helplessness, and hopelessness. One is catastrophizing. So we get the diagnosis of infertility, and oftentimes we catastrophize. I'll never be able to have a baby. I'll never be able to, my legacy will not continue in how I wanted it. And then, all the fantasies that we have attached to having a baby. So it helps us to learn how not to catastrophize, how it helps us not to mind read, because we can assume that we know what other people are thinking, all or none. So there's just different things thinking errors that most people think incorrectly as, and it can teach us how not to do that, because those things drive depression and anxiety. Even couples counseling, and again, support groups can be very helpful. I think having honest conversations about who we are, what we want, our identity as parents. I know my husband and I was 42-ish when I got married, almost 43. And even as a physician, having a baby was not at the forefront of my mind, because I was thinking I just got married. I'm like in shock, right? And so it was my husband who was the one that was like, I think your cycle is off. And by that time, I'm like, I probably was like 45, 46. So I think also having some support around having hard conversations and counseling to help you have hard conversations. We're now in a marital ministry group, and because of that, we're pushing through bringing up things that we've not talked about, and that's a big driver of why. The issues in relationships around the issue become more problematic.
Thank you. Yeah, those are some great tips. And I love that you mentioned mindfulness. And I think it's a simple practice of literally just being aware of what's happening in the moment. And we have so many distractions these days with our cell phones in particular. They're constantly sending little notifications to you all day long if you allow them. And so mindfulness can be a way to really effectively cope with stress that you can control on your own time. So there are so many apps that can help with it, and activities. If you just Google mindfulness, there are a lot of simple things that you can start to employ just on your drive-in, or when you're eating, you can eat mindfully and things like that. So a couple more questions came up on the topic of age. One in particular was whether or not you can use donor eggs if you no longer have a period. So you're, menopausal now perhaps, or maybe you don't have a period because of premature ovarian failure. So I think this would be a good one for Dr. Stafford. And then I have a part 2 for that question once you answer.
Okay, so yes, I have patients who are postmenopausal who use donor eggs and achieve pregnancy. Postmenopausal meaning they don't have periods anymore, to be specific. And so that is a possibility. They typically will give you medications to help with that process.
And then can you talk to us a little bit about just the health implication? I know you and I have both taken care of women even into their 50s that are pregnant. And we talked about Janet Jackson being 50 and pregnant. Can you talk a little bit about the medical risks of pregnancy in older moms and the importance of kind of optimizing these medical conditions like hypertension, for example, for best outcomes?
Absolutely. So generally speaking, we would recommend optimizing these conditions before pregnancy, while making sure the medications you are on are safe for pregnancy, so that when you get pregnant, you can continue on what's been working for you as you veer into your pregnancy. If you do not have these conditions, your age alone plus pregnancy can mean that you're at risk for conditions such as pregnancy-associated diabetes and pregnancy-associated hypertensive disorders, including preeclampsia. So because of that, it is recommended that you optimize everything in terms of your weight and your full mental and physical well-being and before you get pregnant, and then continue that throughout the pregnancy as well to make sure as best you can that those complications do not become a part of your story.
Yeah, I think that was a really good question because I don't want to get too far off of topic, but obviously a lot of us have heard about Black maternal mortality. And when you really dig deep into why people are dying and then who is dying, often it's Black women over the age of 40. That's when the statistic really changes sharply. Like the bulk of that statistic comes from that age group. So although we have the Halle Berrys and the Kenya Moores and the Janet Jacksons and whomever else are making pregnancy in your late 40s and 50s look glorious, it is definitely very risky. And you truly could be putting your life at risk to bring a new life into the world. So you're only going to be better if you're able to optimize all of those things before pregnancy, but single-handedly age alone can kind of tip that number over the top. We talked a little bit about hypertension. Another thing that you mentioned kind of structurally was fibroids. And someone from the audience wanted to kind of ask what that impact could be with fibroids and pregnancy and the case of infertility.
Sure. So fibroids can be a structural cause of infertility. When you think structural, you can think about it like it's in the way. That's the best way I try to describe it to my patients, especially if it's inside the cavity where the baby would grow. That would be something that would make it difficult to get pregnant. Sometimes they also can be really large, and that can cause pain in the uterus before and during pregnancy. And that can also impact the ability for the baby to grow normally because the blood supply is being competed for between the pregnancy and the fibroids because they feed off of blood supply. So because of those things, it can make your pregnancy more difficult to achieve or more risky or painful during the course. And then also in terms of delivery, it can impact how much bleeding you have and whether you need to have a C-section or vaginal delivery. So there are a lot of implications for fibroids throughout pregnancy. So that's something else that you want to know, investigate, and optimize before pregnancy.
Yeah, and I think this is one of my favorite areas is kind of that interface between fibroids and pregnancy. And one of my clinical practice, I work really close with my reproductive center and doing myomectomies, which is the surgery to remove fibroids to help optimize pregnancy outcomes for patients. And someone in the audience highlighted, even though PCOS is where you have infrequent periods, if you're having periods that are too frequent or too heavy, pregnancy, that could be an indicator of fibroids. It might be an indicator of polyps or something else going on. So it's definitely important to also see your doctor if there's a change in the other direction. And you can have an evaluation and workup with your doctor and then decide, if surgery needs to be done. And not every fibroid needs to be removed, but sometimes they do need to be removed in order to have good success with conceiving on your own, or even just to optimize things for preparation for IVF. So a couple more questions. I cannot believe it has already been such a long time and we're nearing the end of our discussion. So for those on Facebook, if you have any kind of last questions, please pass those on in your chat. And then to those who are on the live Zoom, go ahead and get those last questions in the Q&A so we can make sure that we address those. The next question that I had was really about the impact of age once again. And this is kind of a specific question for this audience member, but I wanted to be sure we addressed it. But let's say you are over 35 and you do want to conceive. Is it indicated to kind of go back in and get fertility testing, or do you just have them try on their own? If you needed treatment for your first pregnancy, like, are you automatically going to need treatment for that second pregnancy?
So generally speaking, I recommend patients try for their required amount of time to make the diagnosis. So if you're under 35, that would be tried for 12 months. Typically, 85% of patients on average will get pregnant within that 12 months if they're in that age range. We do shorten it after 35 to 6 months. So right now, I know in our reproductive center, they have a really long wait time for first appointment. So if the patient is very concerned, they can make an appointment because generally speaking, it'll be out sometime. But I typically do recommend trying for that period of time because that's really going to be your best indicator of success.
Yeah, and I think time always feels like it's working against us. Like when we want to get pregnant, it's like, I wanted to be pregnant yesterday, you know what I mean? And so for those of you who are on this call who may have some interest in your own fertility, I think it's really great to empower yourself and kind of know this information so that you kind of walk in the door to a doctor's appointment already informed. So, pat yourself on the back for getting on the call here. I had another medical question, and then we'll kind of probably end with maybe a kind of closing comments from our panelists. So kind of if you have anything that you want to close out with, you can start thinking of that. But the question is, can scarring from fibroid surgery impede the growth of a child?
That is a very specific question. I would say that is a possibility, but not a guarantee. That's the best way I can answer that. And so that would be something you want to definitely talk to your doctor about. Have them, if they did not do the surgery themselves, review the operative report. If you can get access to that, that would be able to help them, guide you on the path towards success. But it's not something where it's a definite guarantee. I personally myself have also had fibroid surgery. And so I, know that that's definitely a risk, but not a guarantee. And so I went into my second IVF cycle with optimism. And I would say that it's not a guarantee that because you had to have treatment before, you need to have it again. But if you have embryos, then you can use them. So that is nice.
Yeah, and I think that's a really good point to bring up. When we think about fibroid scarring, if the fibroids are removed just from the inside of the uterus, sometimes people can think about like the sides of the uterus kind of sticking together and creating scar tissue. And it's not very common, but sometimes it can. So if you've had fibroid surgery, you might have to follow up with your GYN or with your reproductive doctor to look at your cavity to see, is it opening up the way it should, or is there scar tissue there? Is the pathway to your tubes open, or is there scar tissue there? So I agree, this is a very specific question and something that's probably going to be best served like one-on-one with your doctor, but is always something to keep in mind. So we also if you're able to look in the chat, we have a survey there. So if you're able to click on that link, even if you fill it out later, that's really helpful for us for future sessions. I wanted to turn things over to Dr. Sherry first to let us know any closing thoughts just on this kind of impact of mental health and fertility. And then I'll have Rashaan close us out. Oh, you're on mute.
Dr. Cherie said something and it reminded me, and I'm going to end with what she just said, was on this journey, we must search for realistic positivity. So realistic positivity, you have to search for it. That often means that we may have to utilize multiple tools as prayer if we're religious, spirituality, we're using our apps, we're making sure that we're healthy, we're problem solving, we are looking at all things self-care. That means any and all tools needed for physical, mental, emotional, sexual, financial health. That's also our help-seeking behavior. And because suffering and isolation are barriers to the goals that we want. And if we're struggling with those things, we really this is the time, and also guilt, because maybe even past behaviors that can come to play. This is the time that we really need to make sure that we're seeking help and focusing on wellness.
Thank you so much. One of our background folks did want me to address, there was a question about vitamin D. And it's definitely, when we're thinking about kind of our overall health picture, as Black women, often we can have low vitamin D levels. And so it's imperative that when you go for your annual exam, this tends to be with your primary care doctor, that you do get those vitamin D levels checked. And then you're getting the appropriate amount of vitamin D and calcium in your diet every day. And then if you're low, then sometimes you have to do weekly supplements for like three months in order to help raise those levels. And there definitely can be a link between low vitamin D levels and infertility. So thank you for bringing that back to my attention. So Rashaan, I think you have been one of the standout participants. Everybody has really shared their own personal fertility journey, and so I appreciate you all's vulnerability in that. But you have really gone very in depth with your own story, and just wanted to maybe have you close out a bit with, yeah, what's next? I see you smiling. You were obviously willing to be on this panel. Like, how did you do it? What are your tips for those who may be going through this experience?
I think, I'm a realist. I'm a very positive person. I've been, handed some difficult diagnosis in my life. And I think just attitude and mindset is reflective to how you're going to handle things. I think that you have to have a good support system. You have to do your own independent research. I think one thing in working in the medical field, and you guys all know being in the medical field, is that people rely on us to know everything, and we don't know everything. So give your doctor some grace. Take it upon yourself to do your own research, and ask all the questions. Be comfortable with being uncomfortable. I think that I was very inspired by Gabrielle Union's book, We're Gonna Need More Wine. I absolutely love her transparency in it. I think it's a great read for all women, especially Black women, to read that book or get it on audiobook, because it definitely had me tap into that inner strength. And I was just like, this girl's amazing. She told her story, like she's transparent about it and she doesn't care what anybody says. What's next for me is that we're just, looking forward to getting our baby. Like, we're going through all the things. And I mean, I still ask a lot of questions. I'm going to ask questions every step of the way. I text Cherie, like, an hour before the call, I was like, hey, you ever heard of induced lactation? Like still some of the things that are out there still blows my mind, and I'm unfamiliar with it. So, ask questions, know that there are people out there, going through the same thing that you are, and just know that you're not alone and alone, and stay very positive, be stress-free, because it is a lot. If you force yourself and concentrate on, I want a baby, it stresses your body, it stresses your mind, and you have to be in a very peaceful place to go through any of these processes. So that's my advice. Y'all hang in there. You got this. Be great.
Thanks again. And so I see our subcommittee lead, Dr. Nadia Barnett, is back on, and she's going to close us out. Thank you so much. I appreciate all of the information that you shared, and we did drop contact information in the chat for our panelists.
Thank you so much, Dr. Hill, for moderating this. Thank you so much for the panelists for being here tonight. This was such an informative session. We have made it all the way to our end time. I am appreciative of everyone being here, of all the questions that have been asked here in the Zoom chat, as well as on Facebook and YouTube. So many takeaways. I think the number, I have my top 4 takeaways is, really finding a doctor that you can trust to be open and vulnerable is, and I would say across the board, all of your physicians that's involved in taking care of your life, you need to be able to be open and honest with them so they can best treat you. Second, it's never too early to have the discussion about fertility, and being open with your doctor about that, asking questions, any and all questions that you have, ask. Give your overall wellness attention, maybe the same level of attention as you give your career, is very important, as well as seeking out a therapist when you need to. I posted in the chat that I am a therapist who has I have my own therapist. I actually have several therapy friends that I will call on the side if it's after hours. So making sure that we have open conversations about just navigating this journey of life that we're all on independently. Lastly, age is a risk factor. We cannot stop the aging process, and accepting that aging is a part of our development, but that also comes with pros and cons depending on what you want for yourself in your life. And lastly, have a support system that you can be open and honest with, having these conversations with other women of color, Black women, as it relates to not just this topic of infertility or fertility, but just having your village that you can lean on is going to help in your overall wellness and help to likely to decrease your stress level. So thank you so much for being here. We are going to have a break for a few months from this wonderful series, and we will be back in September. Please follow us on our Instagram and Facebook page as it relates to keeping up with our events and our sessions. We appreciate, once again, you all taking your time out to be here, and we hope that you have a wonderful evening and a wonderful rest of the week. Bye-bye.